Everybody. Thank you for joining us this evening for this month's Tuesday Talks. Dr. Long is going to be presenting with us today, talking about psychotropic medication use and behaviors related to dementia. So we do have quite a few people on here tonight. So if you have any questions, please feel free to send those over in the chat and I'll read those off for Dr. Long. As you all know, AltaVita is a locally, privately owned senior living community here in Longmont. We do offer independent living, assisted living, and memory care. Our memory care is a standalone memory care. So we offer assisted living services here in a safe, secured environment. And if you'd like to schedule a tour, I'm more than happy to do that with you guys. Following this, I'll put the contact information in the chat boxes. But for now, I'll turn it over to Dr. Long.
Hi, everyone. I'm Dr. Long. I see a lot of familiar names on the Zoom links. And thanks for taking the time to join. And I am a geriatric psychiatrist who specializes in dementia care and medical director of AltaVita campus. And what I thought would be beneficial is doing the psychotropic medication use in behavior-related dementia illnesses, and because this comes up so many times, because most people, 75% of our patients with dementia end up having some sort of psychiatric illnesses, symptoms. Therefore, I think it's a very important matter. And I think that's why there are a lot of you guys joining today, which is great. And as Adam said, if you don't mind typing in your questions, and then I'll get to them at the end of the talk. So first of all, I wanted to kind of talk about when we talk about dementia, what dementia means. It's, starts with impairment in short-term and long-term memory, impairment in abstract thinking or reasoning, impairment in judgment, personality changes, apraxia, which means forgetting how to do things, and it can be, usually starts with things like using the remote control, using phone or microwave, and then as the dementia progresses, it turns into inability to take care of their own activities of daily living, such as brushing their teeth, brushing their hair, changing their clothes. So unfortunately, it kind of gets worse as it progresses. And then aphasia is difficulty with speech, and it can be in two folds. The first one is expressive aphasia, which is usually at the beginning. People forget using words, or they forget how to make sentences. They misspeak a lot of times. And then the second part is comprehensive aphasia, which becomes more and more difficult for them to understand what you're telling them, which can be source of agitation, because if you don't know what you're being told and what you're about to do, people can get agitated. So if you just walk up to someone and say, Mrs. So-and-so, we're going to go take a shower, and if they don't understand what that means and you're trying to pull them to go take a shower, they're going to get agitated. So that can be a source of agitation, which we'll talk about a little more in a minute. And the reason I put this one up is always, people are always asking, like, so my mom has dementia, right? That doesn't mean she has Alzheimer's, or vice versa. People are like, she has Alzheimer's, she doesn't have dementia. So dementia, as we talked about at the beginning, it's series of symptoms that kind of, it's a cluster of symptoms that means dementia. It's almost like compared to, like if you say I have cancer, then you're like, what type of cancer do you have? So it's kind of the same um, uh, understanding of, you have dementia, what kind of dementia do you have? Number one cause of dementia is Alzheimer's disease, which is why a lot of people, that's the first thing you think about is when you say you have dementia, you think of Alzheimer's. So 55 to 65% of our population with dementia most likely have Alzheimer's. And this is number one risk factor for Alzheimer's is age. So as we live longer, and at this point people are living longer, so we're going to see more and more Alzheimer's. So from age 65 to 74, 3% of people have dementia, jumps up to 17%. From 75 to 84, jumps up to 32%, 85, and it jumps up to 47 to 50% after age 95. So it's kind of an exponential jump with each decade. And then second type is vascular dementia, which is if you've had cardiovascular disease, strokes, mini strokes, TIAs, it puts you at higher risk of vascular dementia. It's a very common type for after having had a heart attack, because you get hypoxic, or you don't get oxygen to the brain for a few minutes. And those people usually end up with vascular dementia. And the vascular dementia, it can be a progressive thing. I mean, they're all progressive, but vascular can happen like that after an event. And that's in about 10 to 15% of dementia population. And there's another one, it's called dementia with Lewy bodies, which a lot of times it looks like these people have Parkinson's disease. Unfortunately, very uncomfortable because they can have visual hallucinations with scary visions. And then this one is very popular with fluctuating level of cognition and confusion. So usually these people sundown really bad. So they may be, more with it in the morning, and by afternoon, 3, 4 p.m., they're very confused, wondering, hallucinating. And because of the Parkinsonian symptoms, they're at higher risk of falls, difficulty feeding themselves. So they end up going down a little quicker than the rest of the type of dementia. And then there's Parkinson's disease with dementia, which is different than dementia with Lewy bodies. And it's basically which one came first, chicken or the egg. So if you have Parkinson's, about 40% risk that after 8 to 10 years of living with Parkinson's, you're going to have, you're going to end up with dementia. And with Lewy body dementia, usually people have memory loss dementia first and then develop Parkinson's. Because that's really important to distinguish between the two, because Parkinson's medications, people with Lewy body do not do well with Parkinson's medications. So it's really important to decipher which one they have first before you start them on something like Cinnamon. Frontotemporal lobe dementia, this one is a hot topic these days because that's what Bruce Willis has, and it's been in the news a lot. And unfortunately, this happens in younger population, like people late 50s, early 60s. It's in 5 to 8% of population of dementia patients have frontotemporal lobe dementias. And usually this is different personality changes start first, like people that were, calm and not agitated, they start getting more agitated. They become hypersexual, disinhibited. And aphasia is affected first, which kind of with exactly with Bruce Willis. Last year, he was diagnosed with aphasia. And then this year, they diagnosed them with frontotemporal lobe dementia. But, it happens in 5 to 8%. And this one I always like to show because the one to the left of the slide, this is your brain on dementia. This is a normal, healthy brain. Hopefully, most of us have this. And the theory is that, people with dementia, with Alzheimer's, get tangles and plaques. So these, and it almost looks like Swiss cheese, the brain of somebody with dementia. And as you can see, as it develops more tangles and more plaques, it atrophies, it gets smaller. Because as you can see, the little crevices in this brain with the Alzheimer's is a lot worse than the normal brain. So this is your brain, like a normal brain, and this is brain with Alzheimer's. And then newer medications, they keep like trying to work on these plaques and tangles because we think this is what's causing the dementia, which we'll also talk about in a minute. So atrophy means shrinkage. So the brain is getting smaller, and usually, as you saw, usually this is the front of the brain. So the frontal lobes are usually smaller than the normal brain. And therefore, with frontal lobes, we call them emotional brakes. And as that part of the brain gets smaller, people can have, they don't have brakes anymore, emotional brakes anymore. So it causes agitation, mood swings, tantrums, unreasonable thinking, unable to reason, or judgment. So somebody who was, caregiver for a household, or, they took care of themselves, as their dementia progresses and this part of their brain shrinks, they start to become unreasonable. And this one also is very good visual because a lot of times I actually show this to caregivers because, as you can see, this is like a normal brain. Hopefully most of us have a lot of red. This is a PET scan study. A lot of red, which means healthy blood flow, glucose metabolism. And as the brain gets Alzheimer's and has those fibrillary tangles, we start seeing, first we start seeing temporal lobe. So it's in the back of the brain, because this is the front of the brain, just for, so this is the front of the brain, this is the back of the brain. So as the early Alzheimer's is setting in, we get the bilateral, like both sides, temporal lobe shrinkage. As it progresses longer and longer, you get the frontal lobe and the temporal lobe. And this is a 5-year-old brain of a child, is a healthy 5-year-old. So, and what I'm trying to show you is that I'm not saying they become a child, but their brain becomes like a child and they going to start acting like a child. With a 5-year-old, you can't reason with them. They don't want to take showers. They don't want to change, and they want to eat sweets. So it's your brain starts to become present itself as a child. And the next slide is I get asked this all the time, like, what can we do? What can I do about my memory? Or unfortunately, and I looked at these dates yesterday because I'm like, I swear there hasn't been anything new since I have my son. And I was right. So Aricept came out in 1996, which is still around. Exelon in 2000, Razodine 2004, um, Memantine or Namenda 2003. So there hasn't been anything new forever, almost 20 years. And none of these actually work for behaviors that much. There's some studies that says that in Lewy body dementia, sometimes Exelon is helpful, but the rest of them are not very effective for behavior problems in dementia. And Namenda, which is in its own little group, is NMDA antagonist, came out in 2003. And if you started early, all of these actually, if you started early, there's a better chance that there's it slows it down, but it doesn't prevent it. So we don't have anything that prevents dementia from happening or developing or advancing. But it slows it down if you start early. And at a later stage, it usually doesn't help. And they all have side effects, especially with these acetylcholinesterase inhibitors. GI side effects are very high, so people get nauseated, they don't eat, they have weight loss. And this one, I put it in just because, again, it's been in the news lately. Leqembi, I think that's how you say it, Leqembi. It got a lot of attention in January because it was fast-tracked by FDA to be approved for an Alzheimer's dementia. But unfortunately, for something, and it's an infusion, it's an antibody treatment to target those amyloid tangles. Remember the brain I showed you that had like little Swiss cheese tangles? So it actually attacks that. And the thought was, hey, Alzheimer's brain has a lot of tangles. If we get rid of those, we're going to see an improvement. And they did see an improvement on imaging. So when they did MRIs, it showed that there was almost actually back to normal level of tangles at the end of the study, which was 18 months. But only 27% modest effect with their memory and cognition. So at the end, and there was only 1,800 people. So right now, this treatment, even though it was FDA approved, fast track, most of physicians are not recommending it because it's not, it's like $4,000 a month to for a very modest, minimal improvement. And I know this is a busy slide, but I'm going to try to break it down, which is just showing how dementia, which is this blue one, has a lot of symptoms in common with depression, which is the yellow, and anxiety, which is the pink box. So dementia, we talked about memory problems, aphasia, apraxia, agnosia, which is you don't remember the words, executive impairment, but also social withdrawal, impaired concentration, sleep disruption, loss of interest, excessive worry, and agitation, which is shared with depression and anxiety, which is this is why it's very important to kind of try to decipher. Yes, demented patient can have depression or anxiety, but what are we treating? Because the treatments are different. I hope that makes sense. If not, you guys can ask questions and I'll go back to it. In BPSD, which stands for behavior psychological symptoms of dementia, as I said before, it happens in 75%. 75% of dementia patients have some sort of neuropsychiatric symptom. And common symptoms include delusions, hallucinations, aggression, restlessness, wandering, apathy, which is kind of like don't care, and not necessarily depression, but they're just apathetic. And disinhibition, which is one of the worst things to deal with because there's not a lot of treatment for that one either. And this causes high stress level in patient and caregivers. And usually this ends up being one of the main causes of people having to move from their home into nursing home placement or memory care placement because caregivers can't handle all these symptoms at home. And obviously it increases healthcare costs because it's cheaper to stay at home versus moving somewhere. And there needs to be higher level of care and supervision for somebody who's experiencing BPSD. And I just want to put it out there that unfortunately there is no FDA approved medications for any of these symptoms, 0. So, and I know when I start people on medications, you get on the internet and, you see all these negative things, and yes, they're out there. These medications that we're going to be talking about have high side effects. They're not good for, they're not recommended for people with dementia. I know that, you know that. I don't have a magic wand, so a lot of times we have to end up using some medications to keep people behavior under better control. And this is not a DSM-5 diagnosis, which means it's not a psychiatric diagnosis. It's series of symptoms. And complaints from caregivers and facilities can be ill-defined. They can be different from each other. Because a lot of times patients do well when they're around their families, and then when the families leave, they start looking for them, or they start getting worried and anxious. So what the caregivers at facilities see versus what the family and loved ones see can be a different picture. And the majority of neuropsychiatric symptoms are unlikely to respond to pharmacotherapy without causing side effects.
Dr. Wong?
Yes.
Real quick, when we're talking about some of these behaviors and in facilities, a proper approach, could the approach of a caregiver or an individual help kind of alleviate some of these behaviors?
Yeah, we'll talk about that in a minute. Yes, it is about approach. It is about, and we'll, I'll go through that in a minute. But the BPSD symptoms, they are, and this is, I've already talked about most of these, but I'll run through it. Physical aggression, when people are like hitting staff members or hitting at a resident, or when they don't want to be changed and they strike at the staff or at the loved one. Verbal aggression. I've had so many people that say, "Oh my gosh, I didn't even know my mom knew that word." Like, they start cursing like sailors. And hallucinations, which can be visual, auditory, or tactile delusions. People can have disinhibition, sexually inappropriate behaviors, repetitive vocalization, which is like sometimes they just sit there and they're just like, help, help, help me, help me. And then you approach them and they don't know what they need help for. Resistance to care, again, which is when you're trying to toilet them or change their soiled pants, they become quite upset. And this to me can be a dignity issue, because my dad had dementia and this was horrible because he never wanted to be changed. He didn't want, these young women changing her, which is usually what is available at facilities. So it was a mess. He would be so upset that he had to be changed, and he did that with my mom too. So it was quite difficult to deal with it for everyone, including himself. And then wandering behavior, and this is usually worse as the sundowning happens, which is 3-4 p.m. Intrusiveness, people can be intrusive, walk into other people's rooms or try to get their attention. They're irritable, they're depressed, they're apathetic. Again, there's a difference between apathetic and depression. Apathetic is just kind of you don't care. Depression is when you feel sad, you don't want to live anymore. So they can be two different things. Anxiety and neediness. And now I'm going to go through a couple of these terms because I know we all get bogged down with what everything means, and it can be pretty confusing for everyone. But the meaning of delusions is fixed false belief. So, trying to correct them or trying to reason with them, it's not going to go anywhere. And you're going to get agitated and they're going to get agitated. So a lot of times living in their in their thoughts is helpful. And I'm not saying be like, oh, okay, yeah, you're going to get killed or whatever, because sometimes those can be the delusional things. But just say, yes, I know, you're safe. We're going to figure this out. But because it is fixed false belief, you're not going to change their mind. And the only thing that's going to happen is you're going to agitate yourself and them by confronting them or conflicting with them. And this is a chemical imbalance. It's a dopamine overload, and patients are not doing it on purpose. Psychosis is also a chemical imbalance. It's secondary to dopamine overload. So visual hallucinations is when people see things. Auditory is when they hear things. Tactile, which I think is the worst type of hallucinations, is when they feel things on their skin. And this happens a lot with Lewy body dementia and Parkinson's dementia. And it's one of the worst things I've ever seen is, there was a lady who always thought there was like a worm coming out of her skin. And even if it was like a hair, she would dig at it because she was trying to get the worms out. People see mouse on their legs or crawling. So they're very scary. So a lot of times, like, try not to reason with them because it's not going to help. Because again, it's a fixed false thought in their head. Try to kind of imagine yourself in their shoes, how scary it can be. And agitation in dementia, 30 to 50%. That's pretty high. But lots of times they're fearful, they're scared due to their confusion. You know, they're disoriented to place and person, that they don't know where they are, who this person next to them is, where their wife is. They can't hear, they can't see, they're afraid of falling. Of course, I'll be agitated too in that situation. And then there can be dignity issues, like I said, about like being changed or toileted by strangers. Pain can be a source of agitation, which a lot of times, you know, because they can't express themselves, it's hard to gauge that, but pain is a big issue. And just think of if they're having delusional thought, which is fixed false belief of somebody is going to hurt them or family member, they start getting agitated. I had one patient who every evening she thought she was forgetting, or she had forgotten to pick up her kids from school. So she was beside herself and would just like turn, go around and around the building. And you would tell her that, oh yeah, well, we called your husband and he's got to go pick him up. And that would kind of calm her down. But when they're delusional and they think like somebody's going to hurt them or their loved one, can be a source of agitation. But it's pretty high, 30 to 50% people have that. But try to exclude there's medical cause. So urinary tract infection can cause agitation, so make sure it's not a UTI. And some anticholinergic medications can cause increased agitation. And I just looked this up and it's pretty amazing because most of these medications, a lot of people are on Coumadin, metoprolol, which is a beta blocker, Lasix, which is a diuretic, Zantac, Effexor, and loratadine Claritin. So a lot of these medications people take, but I mean, sometimes you have to take Coumadin. You can't take it away. But so just be mindful of that use the least amount of these medications as possible to decrease the risk of agitation and confusion. And then remember that 3 box that I showed you, anxiety and depression. So make sure that we're not dealing with some comorbid anxiety and depressive episode. Because if we are, those are pretty easy to treat with SSRIs. Assess and treat for pain, like have some, maybe if that is the problem, have some Tylenol on a daily basis. Like Tylenol is pretty safe to take 3 times a day. And consider opioids. I mean, we try to avoid them, but consider them. And normalizing sleep-wake cycle. I mean, anybody who doesn't sleep well, they don't do well the next day. Melatonin has been shown to be very effective with dementia and circadian rhythm, and bright light therapy. And that was one of the designs at AltaVita memory care, is that there's that patio, that indoor patio, there's always access to light, and it needs to be you know, bright light and during the day. And trazodone and Remeron are helpful too, but always, as Adam was mentioning, initiate with non-pharmacological intervention. We always try to kind of see, you know, come up with an individual plan at the facility, you know, by interviewing the family and seeing the medical records and see who that person is, where they're at the moment with their Alzheimer's or dementia journey, caregiver training. I mean, we do constant training with our caregivers at the facility, but also if somebody lives at home, there are some on Alzheimer's Association website, there are some training videos that people can look at and come up with some plans of how you could deal with this person at home a little different. And then there's a lot of evidence for music therapy, which we love at AltaVita. Pet therapy, we have a lot of animal volunteers that come, dog volunteers that come. Aromatherapy, kind of iffy, but there's some evidence that that works. But the main one is the individualized behavior plan, which we try to do like with care conferences, or even before people moving in, try to come up with what it is that this person had. There was one gentleman that every evening, and that's the thing too, like people usually end up going back to their childhood and where they were at when they were a kid. There was one gentleman that always talked about bringing in the cows, like in the evenings. He was always worried that, we need to bring in the dogs, we need to bring in the cows. And we all thought like he was a rancher. And then talking to his spouse, she was like, no, he hasn't lived on a ranch since he was 12 years old. So he was going back to that stage of his life. So learning about things like that is very important, because with that guy, we were just like, oh, okay, yeah, we're going to go get them. You don't worry, you go have dinner and get ready for bed, and we will get the dog and the cows and whatever else, and just kind of go with it, instead of keeps telling him that there were no cows here. That was 70 years ago. You don't live on a ranch. It's usually better to kind of deal with things a little differently. And some people have told me, that I don't like to lie to my loved one, whatever. I'm like, they're not lies. There's what I call therapeutic lies. It's kind of like therapeutic for you and them. Because if they're not doing well and they're agitated, you're not doing well. So a lot of times I call them therapeutic lies, because they're not completely lies, like, but you don't want them to be anxious all the way too. There was another woman who always in the evenings wanted to move her car, because she said she was going to get a ticket in the evenings. And one time I just said, oh, okay, I'll go move your car. Here, let me have your key and I'll go move your car. And, she was like, oh yeah, my key is in my room. And I was like, okay, I'll go get the key from your room and I'll move your car. And she was so cute. And she goes, oh, that's great. But you don't have to bring the key back tonight, because I'll be asleep. But, we went through that every day, because she would forget and she would have to move her car the next day again. So things like that be nice to do. So now we're going to get into some treatment options for psychosis and agitation. And again, I just want you to know and emphasize there is no FDA approved medication for agitation and psychosis in dementia. There's also all of the antipsychotics, all of them, that's why I put in capital, have black box warning, which what that means is increased mortality rate in patients with dementia, 2 to 3-fold increased risk of cardiovascular events, so heart attack and strokes. So they all have it, but if somebody's psychotic and they think, that they're in danger and the Nazis are coming after them, or the kids are in danger. I don't have a magic wand, so we need to use antipsychotics. And to tell you the truth, I mean, there haven't been a lot of studies with older patients and antipsychotics, and I think it's due to legal stuff, and the pharmaceutical companies have gotten smart about not doing a lot of drug treatment or drug trials in dementia patients, because usually dementia patients have a lot of comorbidities, right? Everybody has heart disease, hypertension, have had previous strokes. So of course, when you put them in the study, it can show that it's due to use of medication, there's increased mortality. However, that was pre-medication, but it's not going to look good under medication trial. So they have stopped doing trials on older patients. But the problem is that we don't have anything better for psychosis and agitation than antipsychotics. And there's been a couple of studies that actually shows Risperdal is pretty helpful. And I put it in the order of what has been proven to be Risperdal, Seroquel, Abilify, and Zyprexa. And these are called atypical antipsychotics, which are kind of newer ones. The old ones are called typical antipsychotics. And usually we try to avoid these unless somebody's on hospice and at the end of their stay, and times we don't use Haldol as much because it has a lot more side effects than the atypical ones or the newer ones. And there has been some studies with mood stabilizers for agitation, including Depakote, gabapentin, and Tegretol, but there's not too many studies, positive studies, showing that there's been a big difference with any of these medications. But that doesn't mean we don't use them. With some patients, there is some benefit.
Dr. Long, there's a question. What are EPS side effects for?
Oh, sorry. Yeah. Extrapyramidal side effects, which is tremors. It looks like you have Parkinson's. People can have tremors, and they can get really shuffling gait, stooped posture, walking slower, and increased risk of falls. And some of the other antipsychotic side effects are weight gain. I'm making this sound really good, aren't I? But I just want to be honest with you and just kind of put it out there, that antipsychotics have a lot of side effects, but I don't have too many options. Weight gain, diabetes, high cholesterol, sedation, which sometimes we use that in our favor because a lot of psychotic patients have insomnia at the same time. They can't sleep at night because of their psychosis. So sometimes we target the medication in the evening to help them with their psychosis, but also help them with their sedation. And then movement disorder, which is extrapyramidal side effect, tremor, slow shuffling gait, stoop posture, and increased level of falls. And sometimes difficulty swallowing. And, difficulty swallowing happens with dementia anyways. As your brain shrinks, it affects the parts of the brain that has to do with swallowing. And sometimes people forget how to swallow. So at the end stages, you've seen people on hospice that they're being spoon fed, and even you're spoon feeding them, they pocket their food. They forget how to swallow. Which that was kind of happening to my dad at the end. He just couldn't figure out what to do with the food, and he would end up spitting it out. So it doesn't mean it's just from that side effect. It can happen also as the dementia progresses. And you can have withdrawal syndrome. So please, if somebody's on these medications, don't stop them abruptly, because they can get even more agitated if you stop them abruptly. And it can cause insomnia, and their psychosis can come back. Their motor disorders can come back. So any of these psychotropic medications should not be stopped abruptly. And then now I'm going to jump into talking about that.
Dr. Long,
Yeah.
real quick. Somebody asked, is sertraline a mood stabilizer?
No, that's the antidepressant, which we're about to talk about. So depression, dementia, it presents differently than younger patients. With a younger patient, you can be sad, you don't want to live anymore. But in older patients, it becomes more of an agitated, irritable presentation, especially with men. They get very irritable and agitated. They tend to isolate more. They have poor appetite. They have poor sleep. They're either sleeping too much or too little. They can have tearful, fearful episodes. But in general, antidepressants have less side effects, right? So even though it takes longer to kick in, but they have less side effects. And anxiety in dementia, this is a chemical imbalance. So there's decreased serotonin, norepinephrine that causes depression, and lower level of dopamine. And anxiety is also a serotonergic and norepinephrine imbalance. So kind of the anxiety and depression kind of go hand in hand. So if you have one, you usually have the other. But the good news is that the medications work for both of them because it increases serotonin level. With anxiety and dementia, there is fear of falling. It's actually number one fear in dementia patients is fear of falling. Which, if you're already anxious and then you're afraid of falling, it increases your anxiety. And disorientation and confusion are very anxiety provoking. So imagine you don't know where you're at, who this person next to you is, and it can be anxiety provoking to kind of figure out what's happening. And delusions and hallucinations, as we talked about before, can cause anxiety, like worrying about your kids, worrying about having to go to work. It had gotten to a point that my dad was so gung-ho about going to work that my mom would put him in the car and pretend like they're going to work and come back, and then he'd already forgotten about, that, okay, I went to work and came back. So there was like a distraction kind of thing. So treatments for both depression and anxiety are the same, which is usually antidepressants, which sertraline is Zoloft, which is a very popular one in this population because it's pretty well tolerated. In here, I put them in order of production or when they came out. So Prozac is the oldest one. Paxil, Zoloft, Celexa, Lexapro, Vibrate, Trintellix. And these are all what we call selective serotonin reuptake inhibitor. So it increases your serotonin level. So this is fluoxetine, paroxetine, sertraline, which is Zoloft, citalopram, acetylopram, and I don't remember what Vibrate's generic name is, and Trintellix, that these last two are so expensive that there's no need. I mean, one of these first 5 usually works. SNRIs are the second choice of treatment, which is selective norepinephrine reuptake inhibitor. So this one not only does serotonin, but it also helps with norepinephrine, which sometimes is better for anxiety. So Effexor and Cymbalta, Prestige, and Fitsima, these last two are so expensive, nobody ever covers them. But from the first two, Effexor tends to be a little more what we call anticholinergic, which I don't know if you remember or not. You don't want too much anticholinergic side effects with the patients. So a lot of times it's a lot easier if patients have failed an SSRI to try an SNRI, or if somebody has severe anxiety and a lot of pain, like neuropathic pain, Cymbalta has been shown to help with pain and depression and anxiety. So again, you have to do a good assessment to see what you're dealing with, and then you get to pick what medication. And Wellbutrin is also a really good antidepressant, but it is what we call an activating antidepressant. It works on the frontal lobe in the dopamine area. So it can give you a buzz. So like if you have anxiety, this is probably not a great choice for you because it can cause anxiety or increase anxiety. But if you have a depression person who is low motivated, low energy, doesn't want to get out of bed, Wellbutrin may be a good choice. And Remeron is completely at the other end of spectrum with the Wellbutrin because it is sedating and it increases your appetite. So if somebody's not sleeping and not eating as well because of their dementia and anxiety, Remeron may be a great choice for them. You just start with Remeron. And it's a great anti-anxiety medication, but it also helps sleep and appetite. TCAs, tricyclic antidepressants, to tell you the truth, nobody ever uses these anymore because of all these good options up here. So sometimes we use trazodone for sleep, not as an antidepressant. Anti-anxiety medications, benzodiazepines, Ativan, Xanax, Klonopin, which we try to stay away from because they also cause increased confusion. They have increased risk fall. They also depress breathing, especially in the evenings. So if somebody has sleep apnea, these are not good choices. There's another one called Buspar, which is a great medication with very minimal side effects. And in younger patients, the studies have not shown that it's really great for anxiety, but in older populations, I found it to be very effective at low doses, but like 3 times a day. So it kind of keeps them chill during the day. And gabapentin, I mean, we use gabapentin for everything. It's, for pain, for anxiety, for insomnia, and originally started as an anti-seizure medication. And guess what? Nobody ever uses this for anti-seizure anymore, but we're using it for all these other things, which are all not FDA approved. None of the gabapentin use is FDA approved, but we use it anyways. And some of the side effects of antidepressant and anti-anxiety medications, for the most part, the dosages that we use for elderly population, you don't have a lot of side effects because we use minimal doses that are effective. But some of the side effects can be your, GI upset, nausea, dry mouth, headache, either diarrhea or constipation, restlessness, more agitation, nervousness. And that's mainly like when you start at a high dose, it can cause these. So that's why you start low, go up slow, is the motto. And they can have side effects of sexual desire or difficulty reaching orgasms. That sometimes we use this as a positive side effect for somebody who's hypersexual, to decrease their libido. You know, when they're acting inappropriately in the facility or at home toward their spouse, we can use some SSRIs to decrease their libido. So they're acting up less under disinhibition. Inability to maintain an erection, rashes, sweating, weight gain, drowsiness, and insomnia. So it depends on which one. Again, I just want to put that out there that please, if you're on yourself or your loved one is on an antidepressant, do not stop them abruptly, because you will have withdrawal side effects or withdrawal symptoms. And sometimes it can be pretty bad. People have told me that they get brain zaps, like in their brain or their spine, and they sound just awful. And they can last for a few weeks. So please, please don't stop it abruptly. Taper off slowly. And this, I always get this question about cannabis for agitation and dementia. And they have been a lot of studies, 12 studies, but 6 of them were randomized controlled trials. The other 6 were not randomized control. And basically what it boils down to, most of them were did not show a high benefit. They all showed low benefit. And the highest quality trial showed no significant improvement. So some of them showed that there was improvement, but the one that had the best control, and it was placebo controlled, showed no significant improvement. And delirium, I just wanted to go over really quickly because I know I have like 5-10 more minutes. This is really important if you see someone who has a rapid change from their baseline level of confusion. So if their baseline level of confusion was here and then they suddenly over hours or days are up here, there's something medical going on. And we need to kind of figure out, and usually number one cause is UTI, so urinary tract infection. And our staff is so good, like the nurses are so great at, they're like, Mrs. So-and-so is so agitated all of a sudden, and I already did a urine dip. Well, because they know that that would be my first ask would be, let's do a urine exam and see, make sure they don't have a UTI. But all these other medical problems can cause it too. Dehydration, pneumonia, flu, COVID, constipation, any kind of stroke, low blood sugar, high blood sugar, thyroid disease, and medications. These are medications that we call they're anticholinergic. Again, I go back to the anticholinergic side effects. Benadryl, pain meds, lithium, Sinemet, which is the Parkinson's medication, anesthesia. So usually I say, if you don't have to have surgery, don't have surgery. And then at the end, with my own dad, they kept wanting to do colonoscopy because he had polyps. And I was like, no, stop doing colonoscopies. He does not need any more anesthesia that my poor mom has to deal with afterwards. And if he dies of polyps, he dies of polyps. So please consider that. Like if your loved one doesn't need surgery or colonoscopy, anesthesias are pretty bad for them. And then alcohol and benzodiazepines, which is those Ativan, Xanax, Klonopin. And drug withdrawals are pretty big. Alcohol, benzodiazepines, and opioids. We've had situations before that I get a consult that so-and-so came for a knee surgery and they're totally delirious and confused. And when you talk to the spouse, they're like, oh yeah, well, and then I ask, like, how much do they drink? They're like, well, not that much, but like 1 or 2 drinks for the past 25 years. So now you got them in the hospital and you abruptly stop it. They are going to have alcohol withdrawal symptoms. And part of it is delirium, which they get confused and agitated. And that has also happened, like when you move somebody into a facility, people are either embarrassed or they don't think it's important enough to say, that their loved one uses alcohol. But then after they move in and everybody's like, oh my God, this person is like doing terrible and they're agitated in the evenings. And then we figure out that they used to drink every day. And now we took their drink away and they're going through withdrawal. And basically with the delirium treatment is you treat the medical problem and it usually corrects itself. But if the agitation and psychosis continues, you're going to need to use some atypical antipsychotics. Usually those are the treatment. And Ativan PRN works too. And then I put this because, we need medications. I get it. But, using the correct drug and using the correct dosage of the drug, targeting the correct condition, like, is this person anxious? Is this person depressed? Is this person agitated because they're not sleeping at night? What are we treating? Because they're not all the same treatment. And realizing if that treatment is appropriate for this particular patient. So let's say if this person has Parkinson's already, there's certain medications that you can't use. So you have to pick and choose the right medication. Because failure of any of these obviously will create side effects. And this is amazing too, risk factors for side effects. 6 or more concurrent chronic conditions, which means like if they have hypertension, if they've had a stroke, if they have thyroid disease, and many of our patients have 6 or more chronic conditions, which ends up being 12 or more doses of drugs per day. People above age 75, they're usually average of 9 to 12 medications per day, which all of these puts them at higher risk of side effects. And if you have low body weight or low fat, it puts you at higher risk for side effects. And usually older people don't eat as well, so it puts them at higher risk. Age 85 and older, or estimated creatinine clearance, which is your kidneys, which, by the way, kidney shrinks as you get older, so you are going to have less creatinine clearance as you get older. So does your liver. So usually you need to consider using less medications. Almost done. Most common drug-drug interactions, they cause confusion, delirium, cognitive problems, hypotension, which means low blood pressure, and therefore falls, acute renal failure. So it's very important to realize what medications people are on. And in summary, I just kind of want to put it out there that behavior and psychological symptoms are very common, 30 to 50% prevalence in our dementia patients. And there are currently no real treatment for dementia. Sadly, I mean, Bruce Willis is a great example of, here's a famous guy with millions of dollars available to him, the best medical care that anybody could ever ask for. And there's just no good treatment for the dementia at the moment. And there are no FDA-approved treatments for behavior disturbances. Initial steps should be addressing potential medical problems and implementing behavior interventions like Adam was talking about earlier. And if all fails, you know, I do need to use atypical antipsychotics, which are the most effective at this point for aggression and psychosis, but obviously have high rate of side effects and black box warning. And making sure that medications are not stopped abruptly is very important because it's very uncomfortable for the patient and can increase behaviors. Sorry, I went over time just a little. And I wanted to end with this because I think this is such a great visual of what's happening to the brain of our loved ones. And, you know, they're not acting out on purpose, and there's a chemical imbalance in their brain. And again, I don't have a magic wand, therefore we need to use medications. But I'm open for questions. I know I went a little over time. Sorry.
You're good, Dr. Long. I think it was really great to hear all of that, and I always have to put this in every time we do a presentation. This is my favorite slide because it kind of really does put things in perspective for people. So I'm glad that you have that one up, and we'll leave that there. So there are a couple of questions. So briefly, would you mind talking a little bit about giving dementia patients simple tasks like folding towels and tactile objects and other ways to help dementia patients?
Yes, always. That's a great idea because we all want to be feel needed, right, and purposeful. So, and here's a person who has been involved with working, taking care of their children, taking care of a household, and then all of a sudden, because of their dementia and being unsafe, you can't do any of those. You can't drive, you can't cook, you can't take your own medications. So feeling needed and purposeful is very important. And yes, folding towels, like washing mushrooms, washing vegetables, like getting them involved in table setting. It can be very important. And even at the facility, sometimes, you know, we just, there was one lady who loved folding little towels. So her family had brought in like this whole big bucket of washcloth, and she would fold them. And then the caregivers would like just dump them out next to her again, and she will refold them again. So something simple like that. And then on Alzheimer's Association .org, ALZ.org, they have a lot of different activities that are appropriate for different stages. Would be very important. But yeah, please try to remember, like, this person, I'm not saying they're a child, but their brain looks like a child, and you just have to kind of make sure that they're safe. And yes, there are some things that they can't do anymore, but there are things that they can. And get the family involved. I know my dad used to love being with my kids. And it became harder as they became teenagers, but, and, you know, had their own thing to do. But my dad loved spending time with the grandkids. And they would just play simple games, you know, card games, and it didn't have to have rules. He didn't know that there were no rules involved. And so yeah, simple things are wonderful.
And I really love that approach, because I did have a resident a few months ago who really wanted to help sweep. I was in the house, one of the houses, helping sweep. And he came up to me, can I help you? And I said, no, I
Aw.
got it. I got it. And he goes, okay. And he comes back, can I help you? And I said, no, it's okay. And then he came back and he's like, look, I really just want to help you, sweet. I'm like, oh, okay, go for it.
Right,
And
right.
it made his day, you know, it made such a difference to just let him do that. And he had that sense of purpose.
Mm-hmm.
So would it be better better practice to treat depression or anxiety with medications first before turning to psychotropic medications?
Treat them with what first?
To treat the depression or anxiety with those types of medications first before going to a psychotropic medication.
So psychotropic medications is antidepressant and anti-anxiety is in that category. But if it's pure depression and anxiety, treating it with an SSRI is preferable. And usually we start with something like Celexa, which is citalopram, or Zoloft, which is sertraline. But yes, I mean, there is a chemical imbalance because of what you're seeing on the screen, which is your frontal lobes are shrinking, your parietal lobes are shrinking, and you don't have enough serotonin production. Therefore, you need extra serotonin to not be anxious, not be depressed. And you know, the unfortunate thing is that, and you know, when you're younger, I always recommend psychotherapy first. You know, let's see if you get better with a few sessions of psychotherapy. But people with dementia, they don't remember from therapy to therapy, so that's not as effective. So medications are usually the answer.
Could you briefly talk about the specific gene that is said to put you at risk for Alzheimer's?
So yes, I mean it is there. There are several actually, but just because you have that gene doesn't mean you're going to develop. You're at higher risk. Doesn't mean you're going to develop Alzheimer's. And at the moment, it's not recommended for you to test yourself to see if you have that gene or not, because we don't have a lot of information what to do with that information. And you live 20 years thinking that, oh, I'm going to get dementia, and you may never get dementia. So it's not as easy as to say, oh, I'm going to get tested and see if I'll develop dementia or not. And another thing with that is if it gets in your health record that you have that gene, then it makes it more difficult for you to get insurance at a later time if you need to, you know, like life insurance or disability or long-term care insurances. So keep that in mind too. But we're not there yet to say, oh, I'm going to do a gene test and see if I'm going to get dementia or not. So it's not recommended just yet.
You mentioned Ativan as needed. Can you speak a little bit about what level of Ativan is okay on that basis versus using it on a scheduled dose? The concern would be overuse of the as needed designation, given the potential side effects of these drugs.
Yes.
And I think it might be important with this question too, coming from a facility standpoint, to talk about just on our end, using as needed psychotropic medications and how we can or cannot do that too.
Yeah. So I actually do not like using Ativan PRN. That one slide was talking about delirium and using Ativan PRN, not for dementia. But I mean, if somebody is on hospice and at the end of their life, yes, we should use Ativan PRN, Haldol PRN, which PRN means as needed. But I'm not a fan of Ativan PRN. because of just that, you're leaving it to the discretion of the caregiver, needing some rest rather than treating the basic problem, which is maybe the serotonin causing this person have anxiety disorder. And sometimes too, I've gotten calls before, like when they're in the hospital. I used to work at the hospital, and the nurse is calling because I wouldn't do that either in the hospital. I'm like, no, you need to call me if this person needs an Ativan PRN. And they would call me, and I'm like listening to the nurse's voice. I'm like, do you need an Ativan PRN or the patient does? Because, dealing with the person, it becomes really hard for you too as a caregiver. So to answer the question, I do not prefer using anything PRN, including Ativan. It has its place for end of life, or if you had just moved in and we need something quick, because Ativan works in 20 to 30 minutes and it's good for 3 to 4 hours. So if somebody had just moved in and they just cannot settle down, and so there's certain circumstances, but in general, I do not like using Ativan because of high risk of falls. And actually, there was several months ago, it was September of 2022, that there was a big study that came out talking about increased risk of dementia with chronic use of benzodiazepines, which is Ativan, Xanax, Klonopin, Ambien, and the Z medications, which is the sleep aids. So there's all these studies that say, those medications are not long-term, are not good for you. So try to avoid them.
And I believe I may be speaking a little out of turn, but I believe in our community, our regulations state that we can't even use
in facilities, especially ALF, assisted living facilities. You're not supposed to use as needed medications. Usually, like I said, if you end up on hospice, so if hospice is involved, it can be used as needed because they have their own nurses that can assess the situation. And then if they're in the regular hospital, like in medical unit or ICU, they can be used. And some nursing homes use as needed medications, but in assisted living facilities, we cannot use PRNs.
We wouldn't have a caregiver assessing that they would be appropriate for
and
that.
I wouldn't want to put that on like a CNA, like
right.
This, young person who doesn't have experience. You wouldn't want to put that responsibility on that person to assess that. So no, we don't usually use that.
And then we have one last question here. Any thoughts on blood thinners impacting BPSD?
So like I don't know if you remember or not, but there was a slide about Coumadin, which is a blood thinner that has been shown to be anticholinergic, which therefore I keep using anticholinergic side effect, which means it increases confusion and agitation. So yes, there is increased risk of increased depression, increased confusion, increased agitation with the use of Coumadin. But if this person needs their Coumadin to stay alive, you're just gonna have to deal with the agitation on the side. But there has been studies that shown that it does increase level of confusion and agitation.
Awesome. Well, thank you so much, Dr. Long, for doing this tonight. It was really great. I love learning from you. For everybody who's still on this, it has been recorded, so we will make sure we get this posted on our Facebook, or not our Facebook page, sorry, our website, as well as our YouTube page. So you can review this later or share it with somebody who you think that might need to see it. And then Dr. Long has also done other presentations that you can find on there that may be very helpful for you. So again, Dr. Long, thank you so much. And please keep an eye out for our upcoming Tuesday talks next month that will be presented by the Alzheimer's Association, which will be understanding Alzheimer's and dementia, which will be really good. So thank you, Dr. Long. I appreciate it. This was wonderful.
Yes, good to see you, and I don't see anybody else, but it's a weird way of doing presentations on Zoom, but we did it.
We did it. Well, thank you everybody for joining us, and I hope you guys all have a wonderful evening.
All right, bye.
Bye, Dr. Long.
Mm-hmm.